thank you very much for joining us. My name's Daniel Walkley. I'm a musculoskeletal sonographer from Adelaide, Australia, and I'm running this podcast, this little interview with. I have the great pleasure of interviewing Iñigo Iriarte. I first came to know about you just from some of your images, really. I saw a few floating around in a few papers, and then saw the amazing work that was coming out on Twitter just from your medical illustrations, and then into your textbook as well. It's and your YouTube channel as well. It's phenomenal. So Iñigo, you're a rehabilitation physician from Spain.
Yeah.
From Bilbao.
Bilbao. Yes.
Yeah, home of the Guggenheim.
Sorry.
Home of the Guggenheim.
I don't understand.
The titanium building, the really pretty building.
Yes, the Guggenheim. Sorry, yeah,
that's all right. My pronunciation is probably horrible.
Yeah, no. It's my hearing not very good.
Okay. Yeah, that giant building.
yes. Bilbao is a small city in the north of Spain. Okay, and I kindly invite you to come here when you want.
No, I'd love to. When we can travel again. I'd love to get up there.
Yes,
really enjoy Spain. But let's get stuck into you. This is what we hear. No one wants to hear about me. They want to hear about you. So let's talk a little bit about your background, your pathway. How did you get into medicine? How did you become a rehab physician?
Okay, all my families are physicians. My paternal grandfather, my maternal grandfather. So my father chose physician. So this is a business family. Okay, family business. Sorry, and so I started studying medicine and finished medicine degree in 1995, and then I began my rehabilitation specialty and ended it at 2000. Okay. So I started my private practice on 2000 here in Bilbao, and I choose only to see musculoskeletal pathologies because I like it the most. And I began my clinical practice in 2000. So
it's a pure musculoskeletal practice?
Yes, only musculoskeletal practice. Yes. 2 years only.
Yeah, I think it's a good way to be good at something when you have a very narrow field.
Yes, medicine is too complicated to see in a specific manner. It's very, very large area. So I focused on musculoskeletal practice.
Yeah, lovely, excellent. So what's a typical day for you? How many patients do you usually see? What's your scope of patients practice? Pretty variable.
Okay, I try to focus on quality. So I usually, in a complete day, I usually see no more than 15 patients. Yep. Sometimes, it's very hard to be under 20 patients, but I always try 15 patients, 16 patients per day. Okay. And I have I work in different places. So I have my own consultation in Bilbao, and I work there 2 days per week. Okay, and I diagnose and perform sonographies, and I am a clinician. So first of all, I am a clinician physician, and I usually use ultrasound to improve my diagnosis as a tool for the clinical assessment. Okay. On Thursdays, I go to Lezama. Lezama is a small village near Bilbao, and the athletic club, which is a professional soccer team in the league here in Spain. I work with them on Tuesdays, and I go there to their facilities in Lezama to perform the ultrasounds there and to help classify muscle injuries. I started 3 years ago with them. Okay, and on Fridays,
get a nice exposure of fresh injuries.
Yes, very, very interesting. Fresh injuries, good assessment with ultrasound and with MRI. Yep. And very close contact with the physiotherapist and the medical staff. So it's very, very interesting for me. Okay, and do
you find working in a clinic where you have a lot of lot of acute injuries, a lot of sports physicians, a lot of physiotherapists, and the MRI correlation. Do you find that helps your scanning, helps your ultrasound?
Yes. MRI, the correlation between ultrasound and MRI is very, very interesting. Because sometimes you are not very sure with ultrasound, and if you have the feedback of the MRI, you can always learn how to improve your ultrasound. So it's very, very interesting. If you can, it's very, very interesting.
Yeah, I think it keeps you honest, really.
Yeah,
and
yes.
It really refines you.
Yes, certain areas are still dark to the ultrasound, or at least for me. And you must always be open to learn and to improve your skills. So I'm always learning from other colleagues, from the MRI, physiotherapists, always trying to learn. Okay, so that's why I think that ultrasound is so fantastic, because it's always improving. No, you never have this sensation of total control. You need always to have doubts to improve. Okay. And finally, on a Friday, I go to Santander. Santander is another city close to Bilbao, 1 hour by car. And I work there in a radiologist clinic, and I perform ultrasound procedures.
Yes.
And also I have contact with a very, very high skilled radiologist in musculoskeletal MRI, with a 3 Teslas MRI and fantastic images. So I'm very, very, very happy there. Mm-hmm.
Fantastic. So how long have you been scanning for? How long have you been incorporating ultrasound into your practice?
I started 10 years ago.
Okay.
10 years ago, yes.
It's a steep learning curve.
Accidentally. A friend told me, you need to start performing ultrasound. I thought, ultrasound is kind of abstract thing. only high skilled radiologists with high expensive machines can probably see something, and it's not for me, no. But I went to a course. I saw Martinoli and values with those amazing images. Oh, this is a tendon. Wow, this is a nerve. This is a small nerve. This is the median nerve. Ulnar nerve. I was amazed, and I returned to Bilbao, and I told my associate, I have an associate, Dr. Said, works with me. We need to buy a machine, ultrasound machine, and in 2 weeks we bought our first ultrasound machine.
Yeah. What areas did you? Yeah. Well, what areas did you start scanning first?
The most common area in my clinic is shoulder, without doubt. Yes, shoulder was the first one. And the following one may be knee and ankle, perhaps in this order. But shoulder is the most common, without doubt.
Yeah. Mm-hmm. A lot of interventional procedures in your clinic.
Yes, in Santander is all interventional procedures. In my own clinic, I perform some, but I try always to start with a conservative approach. And I have 3 physiotherapists working with me, and we almost always try first with physiotherapy or exercises or conservative treatment. And yes, we use ultrasound procedures, but not so much in my clinic.
Yep, just more of a diagnostic and prognostic work.
Yes, it's a very useful tool for diagnosis and for treatment. You know? But usually diagnosis is a common thing in every day, and procedures sometimes I don't perform no procedures. Another we have 3, 4, 5, but in Santander they 14, 15 procedures per day.
Yeah. Yeah, it keeps you busy, keeps you on your toes.
Yes, Santander is always busy. Yes.
So you touched on earlier that some areas we find ultrasound really hard to make the diagnosis. Some are a bit of a dark art, some are a bit of a tested area. What areas do you find hard? What do you find challenging?
Okay, at first, hip. For me, hip was the most difficult one because of its depth. And because of the kind of patient, usually old patients with fat tissue, not a good images.
Poor acoustic windows. Yep.
Yes. A difficult area for me at the beginning. Now I feel more comfortable, but the beginning was for me the more difficult area. And any area you need to scan with depth, more than 4 centimeters, you begin to suffer. If you need to see some details, you begin to suffer. Okay, ligaments, joints, always difficult to be sure you're seeing something important. Okay, hip the more difficult, yes, without doubt.
My pet hate at the moment, and also the pet thing I'm kind of pushing on a little bit at the moment is the salil injuries and acute salil injuries at the moment.
Yes.
A lot of work with Carlos Pudet and all that's kind of really opened my eyes there to where I should be looking, what I should be looking for.
Yes, totally agree. If we are talking about muscle injuries, I think the most difficult areas to evaluate are soleus, sure, but also to be sure that you have or not a tendon disruption, a tendon tear. No? For example, in common conjoint tendon in the hamstrings, for example, no.
Yes.
Is very important if the common tendon is injured, has a tear or not, and sometimes with ultrasound it's difficult. This kind of patients have a very good acoustic window usually, but sometimes it's difficult to be sure, and still MRI is clearly superior to ultrasound to have a good assessment of specific assessment of these injuries. Mm-hmm.
Actually, I might digress a little bit and just talk a little bit about those hamstring injuries and whether that central tendon, that intramuscular tendon's involved. We're over here in Australia, in the higher level sporting population, they're operating quite a bit on if the intramuscular tendon's involved in the high level athletes. Is that happening over there as well? Is that a common thing that happens? They try to repair that intramuscular tendon?
Yes, here in Spain, you're talking about the distal intramuscular tendon of the long head of the biceps?
Correct.
Okay. Yes, it's also very frequent here, but maybe in men in soccer in the first teams not so frequent. We see a lot of affection of the proximal tendon, of the conjoint tendon between semitendinosus and biceps femoris. The distal part of the long head of the biceps is not affected so easily here, at least.
Okay. So it's always interesting to see what other people in other parts of the world are doing. So.
Yeah.
Very nice. So how many out of those 15 patients that you see a day, how many of them would you ultrasound, do you think?
How many of them?
Yeah, of your 15 patients that you see per day in your clinic, about how many of them would you scan? How many of them would you perform an ultrasound on?
Okay.
Average.
Almost all, if they have peripheral pathologies. So I don't scan backs or necks, usually. Yep. But if they have something in my first consultation, if they have something in the knees or elbows or wrists or in the periphery, I almost always perform a scan because it's always information, and all the information you have is always useful. I perform 15, I don't know, 10, 11 scans per day in my consultation. Yes.
Yeah, so you find that, actually giving the patient a true diagnosis and giving them the information in the context of their setting is advantageous to their rehab and their recovery? Yes.
Usually, doing a good anamnesis, a good exploration, you have an idea of what is the problem or a good diagnosis, but it's difficult to assess the how important is this injury. For example, you can suspect or diagnose gastrocnemius injury with the exploration, but if this is a grade 2 or grade 3, or grade 4 is almost impossible only by your clinic exploration. So you use the ultrasound to complement this exploration, and you have an accurate view of the injury itself. You can check for potential complications like delayed hematoma, for example,
yes.
or new re-injuries, for example. It's difficult to assess only with clinical suspicion, or even deep vein thrombosis, for example. I had quite a lot of deep vein thrombosis. I'm sure it's far more frequent than we think. Okay.
Yes.
And these things help a lot in the treatment. So I can tell the physiotherapist, be careful with this thing, or you can do whatever you want, depending on the ultrasound.
Got to push them a bit harder.
Yes.
I
Very
find
useful.
I find there's such a big push at the moment, particularly from the physiotherapy field, and especially on social media, to kind of avoid diagnosis, to kind of step away and give people these non-specific labels. The rotator cuff related shoulder pain, and is it worthwhile identifying particular structures at fault, whether that comes into context and how that helps people.
Yes, is as useful as a positive diagnosis as a negative one. So if you think something and you see that the ultrasound is normal, very important information. No, maybe I am wrong, or the problem is in any other place. I don't know. I think it's very, very useful. I cannot think about my consultation without the ultrasound. Is far more is worse. I'm sure it's worse than with ultrasound. Sure, totally sure.
Yeah, I tend to find the people that criticise it are the people who don't use it in their practice, I think. And imaging's useless without clinical correlation as well.
Sure.
So that's the other thing as well. So you look at the findings, and if they're not sore and it doesn't fit, then it's not really part of their diagnosis. And I think that's where people get a little bit hung up. Is you can't have one without the other. Yes,
they are totally complementary, and lots of false positives also are present. So it's very important, the correlation with the clinic. This is mandatory, okay? But the conjunction, the union of the two techniques is very, very powerful. When I speak with radiologists, they usually don't have the clinical skills we have, and they feel they feel the need to learn more about clinical exploration. Okay, they realize this is very important for them, and they now are learning clinical exploration to perform better diagnosis with this. And the MRI has the same problem.
Yeah, that's right.
Yes. Usually we send...
You rely on the clinical information that's on the request form,
Yes, you send a patient without clinical information to the radiologist, which is blind to search something, no?
That's right, shoulder pain. Yeah.
Yes, they search in the whole knee, for example, pathology, no. They need to focus in the area. They need to be guided with a good clinician exploration, and this is now it's not fancy. We don't spend the time with the patients. We send it directly to complementary exams, and this is a great error. We are now the present is we need to dedicate time to the patients, to spend time with patients, and for that is very useful to have the ultrasound just in the clinic to explore the patient after the clinical assessment. For me, it's mandatory.
Excellent. Yeah. Let's change a little bit. Let's change topics a little bit. So we've spoken a bit about your clinical background, the way you work in your clinic, your imaging modalities of choice, and then we've got this other arm to you of medical illustration. Right? These fantastic pictures you produce. Like they are spectacular. They are absolutely spectacular.
Thank you very much.
For those who haven't seen it, like get out there, have a look at Inigo's. Have a look at his YouTube, the English version, MSK Freak, or get to his book, which we'll talk about in a minute. But those renderings, they're unbelievable. They're so lifelike. They're beautiful.
Thank you very much. I liked drawing a lot, and when I started with ultrasound, I realized that it was very difficult for me to translate the 2D images of the drawings of the usual anatomy books like Prometheus or Sobota or other books. It's very difficult to learn sonanatomy with 2D images.
Yes.
To understand properly. Now with ultrasound, we have an amazing tool with very, very specific anatomy requirements. No, so this has changed a lot, and I thought that all the classic texts were not enough, at least for me. And I like to draw, so I started with Photoshop.
Yep.
Yes. And my first book was in 2005, okay? Right. And I began my drawings there because I think that was for me important to communicate what I wanted to communicate to the reader, okay? So I started with Photoshop, and but some axial images were difficult to perform. And in the internet, I saw a tutorial about the Man of Steel icon, okay, and how to draw it in 3D. And I tried with the muscles, and I had a pretty good result. And I started with 3D, and I like it very much. And it's my kind of hobby for me. And I was improving month by month. And now, if you take a look to the shoulder chapter, okay, anatomy of the shoulder, in the book, this is the last drawings I made, and I'm really proud of. I think that they are very, very nice ones. And 3D has an advantage. You can turn the image. You can just show what you want to
show the aspect and give a view just where you want to be. Because it's beautifully rendered 3D images that you draw. And all the images, they have this real wet pro section kind of anatomy. It's like you're looking you're looking at a cadaver, but it's got pretty colours. Really, it's a very pretty coloured wet cadaver.
This was the objective, to have a final image like a cadaver-like, but with the simplicity of a drawing, no, showing. Not a real image, but because I have the ultrasound vision, so I can change a little bit the image to show some structure the way you must understand the ultrasound. So it is very difficult to do this with if there's no you, the person who made yourself the drawing. No? So that's why I started and learning and improving. And now,
it's very good. How long does it take you to produce a drawing? When I've listened to Matt Slavaski and his beautiful drawing, he really works on that anal perfectiveness, and he reckons he's 10 to 15 hours per drawing is how long he takes on average. Sometimes longer, sometimes less. But yeah. Okay.
There's not time per drawing because there's not a drawing itself. It depends on the structure. So, for example, if I want a picture of the deep gluteal space, for example, I need to draw the gluteus maximus, the piriformis, the obturator internus, gemelli, and all the muscles one by one, okay, and in a 3D manner. Okay, so you need to sculpt each structure, give this structure the correct volume, the correct orientation, the correct origin and insertion, okay, and to paint it, okay. Once you have created a muscle, you can have all the drawings you want, all the images you want, because you only need to turn it or to place the light in this way, and an image will take 2 minutes to have this image, okay. But each muscle is like a nightmare, okay. So for
how do you start out? How do you start? Let's say say you're talking about drawing the gluteals, right? How do you go out about drawing gluteus medius? Like where do you start?
Where?
Yeah.
So, what are they started? Sorry, I don't understand the question.
That's right. So when you're starting out, you're saying that you build layers upon layers to create your area of the body that then you can remove and change the angle with.
Okay.
How do you start out? You start out with the skeleton. You start out with muscle.
Yes, with bones. Yes, always with bones.
Yep.
And now I can extract bones from a CT scan, a real CT scan.
Yep.
Okay, and then work with them till I have the final result, but always with the bones, because I need the origin and the insertion, and always with the bones. Then I follow with the muscles, okay, and finally the nerves or the ligaments or other structures. But this
so
is
you'll start with a CT image and kind of trace over that and copy over that to get the proportions right, and then work from there. Yeah.
Only for bones. Huh? I use the bones, but the muscles are made by myself, starting from zero. Okay, it's like a sculpting. It's like you have a sphere. You modify the sphere till it has the volume and the muscle you want. And then you need to paint it, and all this process is complex.
Did you draw a lot as a child?
Yes, I always like to draw, but not. I didn't have the time, right. So when I began the university, I ended my drawings and I suspended it. And medicine was very demanding, so I didn't draw. I started drawing with my first book in 2005, and I started again drawings.
Yep. Excellent. So let's talk about your book. That's a nice segue. So, we've got the traditional Bible. Ultrasound of Musculoskeletal System, Bianchi and Martinoli. We've got John Jacobson's beautiful book. We've got, who else do we have? Who do we have? Like Eugene McNally's lovely book.
Yeah.
And then we have this one, your lovely book, Ultrasound of a Musculoskeletal System, by yourself, Carlos Ramos and Lewis. And it is spectacular. Like, this is the new Bible. This book is the new musculoskeletal Bible, I think.
Very kind.
It's like when you originally read Martinoli and Bianchi's book, and you read that and you go, it's a good book. Like, this is really good. This is a great text. It makes sense. You don't disagree with a lot of it, and it's very applicable, and starts from basic foundations to a pretty advanced level. And I think, mate, I think yours has really taken it next level. Like, it's you read it, you have a look at it, and you go, this is fantastic. And the illustrations, like, they're unbelievable. They're so nice. How do you go about writing a book? How do you go about this?
I always wanted to. I like a lot teaching. Okay, I like a lot of teaching, and I am a very huge fan of Martinoli's and Bianchi's book. But it's from 2007. So the ultrasound has changed, has evolved, and now the images are better, new structures are better learned, and I think something new I needed to communicate. I have contacts with very experienced sonographers here in Spain, and they all wanted to participate, so I need to do this, no? And that's why I tried. Here in Spain, all began with an online course, only in Spanish for now. Sorry, and I told the editorial, I want to make a book from these contents. Oh no, books are not they're not worth it because they give no money, so we don't want to make a book. But the course has a success, and after 2 years of the course, they call me, what if we make a book? Perfect, that's a good idea. So that's why we started with a book here in Spanish first,
Yep.
And I decided to translate it to English because all this work, it was a pity that it ended only in Spanish. So
such a small cohort when you can get a lot of worldwide
Yes,
and like it's great. Everyone I'm speaking to, I'm hearing new people. Have you seen this? Have you had a look at this? And yeah, it's phenomenal. It's really good. How did you get the rest of the band together? How did you get Carls and Raymond and Lewis in together?
They are friends of mine. So we met in different courses here in Spain. We developed a very good friendship. And they all thought the same as me that a book was very interesting to release with all the knowledge we had, all the contacts we had, and so that's why they were very very prone to do the effort to do the book, and so I had no problem with contact with them to help me.
How do you divide the workload with your authors? Do you pick a topic and just go individually and then work collaboratively together afterwards? Or?
Sorry, I don't understand.
That's all right. When you go about this, when you're working with the other authors, how do you go about putting it together? Do you go, all right, Carls, I want you to write a thing on calf injuries and put it together and.
They work together, Carlos and Ramon Valios. They work together, so they are used to work together, so no problem at all. And Luis Cerezal is the radiologist I told you that was with me in Santander, so we have a close contact too, so no problem at all. We had other friends which have some areas of expertise. We profit to write different areas of ultrasound. My associate, Dr. Saif, wrote about the hip, and so all we were very very close, have a very close relationship. So it was very easy to organize the book. No problem.
Did you learn a lot from the process?
Yes. A lot. That's one of when I started with ultrasound. There was in 2012, more or less. The next year, I decided to organize here in Bilbao the first course to learn myself.
Right. Okay.
Yes,
is that the ARS course that you're in?
Yes, our ARS course. Yes, we have a course annually here in Spain.
Do it in English so I can understand it.
Yes, I want.
I had a look at your recent recordings and you said, "Oh, like this looks fantastic." And like, I understand a few of the names, but
yes, there's a lack of time. I
need to be bilingual. I need the skills, but it looks really good.
I'm working on it. I'm working on. I have projects for this year, 2023, and I'm developing a website of learning and teaching ultrasound with English content and Spanish one. And this is my purpose for this next 2 years because I'm trying to improve my English. Still not the best in the world, but I'm trying to improve it.
I think it's pretty good, Inigo. I think it's very good.
It's difficult when you want to communicate technical things. The way of talking relaxed and it's important because it's the difficult stuff, no? So
you're doing a great job. You're doing a very good job.
Thank you very much. You're very kind. This is my project for 2022 and 2023 is this website with all this content, and it's a very ambitious project. I hope. The advantage is that you don't need to have all finished to start. You can start with some few areas and
add modules as you go.
Yes, if people likes it, you can improve it and get it bigger. I want to establish an international group with people like you, for example, to change impressions. I think that experience is very important. papers are good, okay? Papers are very good, but experience is very important. You cannot communicate experience in papers. So these small circles of experts, for me, is very, very interesting. And this is the project I want to establish for the next year.
That's where you're dedicating your time now?
I will be in touch with you.
So that's the next project, that's the next focus?
Yeah, but also it's always a lack of time. So I have a family, I have my wife, my children. So the book has been very, very demanding. And
how long did it take, start to finish, this book?
We took 4 years.
Yeah.
Wow. 4 years.
Yeah, looks like an incredible amount of work has gone into it. Like, absolutely incredible. Like, I don't think people really understand, like, just from writing academic papers, how much work goes into that, let alone writing a text of pages on pages and pages. When you work so hard to write, 5 pages for an academic text, how much goes into a 300-page book?
Yes, and when you have a schedule to accomplish, it becomes very stressful, because always people, I need more time. We don't have time, and it becomes very stressful. So this is why I decided to take a break. This first half of the 2022 to recover, and in the second half I think that I can start again with plenty of energy and come. I really think I have very, very good material to show. I hope it's evolving, it's getting good, and I hope that in the second half of 2022, the website it will be called MSK Freak, and I hope it can begin in 2024. Let's see.
I'm waiting in bated breath. I'm very keen. I'm very keen to see what you have. I'm sure it'll be phenomenal. I'm sure it'll be another standard that people need to attest to try to promote their products.
The content will be directed towards beginners, intermediate, or advanced sonographers, different areas, anatomy, pathology, with short videos, 50 minutes, not to be very tired, in an easy manner. I am thinking about it, but I think it will be a great resource. I hope.
I'm sure it will be. Dr. Iñigo Iriarte, thank you so much for your time. I'm sure everyone appreciates what you do, and I've learned a lot from your drawings, your pictures, and your text itself. So, for those of you interested, Ultrasound of the Musculoskeletal System, this book here is sensational. If you don't have it in your book rack, and you're doing musculoskeletal imaging, you're doing something wrong. You need to have it. If not, your YouTube channel is phenomenal as well. So MSK Freak is the English one, and Iñigo Iriarte is the Spanish one. Is that? It's
Iñigo Iriarte.
Iñigo Iriarte.
It's in Spanish, and MSK Freak is the same content but in English.
It's phenomenal. So, if you have some time on your hands and you want to improve your knowledge base, follow Iñigo's work. It's really good.
Thank you very much.
Dr. Iñigo Iriarte, thank you so much for your time. I really appreciate it, and we'll let you enjoy your day.
Welcome.
Thank you so much.
Thank you very much to you, Daniel. Have a good time.
Thank you.